patient-focused events, which if you have any of your patients who may be interested, we have some cosmetic surgery one-to-ones, and we're back to doing our varicose vein events face-to-face as well. We also have got a menopause event, but that is taking place in the Nuneaton Fitness and Wellbeing Gym. So really that's all from me, other than to say that at the end we will put up something for you to fill in the feedback form online, and we do ask you to do that, please, because it's helpful for the consultant and it's helpful for us to know what you would like in the future. So I've taken up enough of your time. I would like to hand over to Mr Kaba, who is a consultant urological surgeon at Swift. I'm sure he will do a bit more of an introduction about himself, but thank you very much for giving up your time, Mr Kaba.
Thank
and,
you.
I will
Mel
hand
and
over
everyone,
to
can you hear me?
Yes, we can.
Thank you. Thank you all for having me today. I'm here to talk about men's cancer care, prostate, testicular and penile, and their one-day essentials in men's health, and what to anticipate and forecast in day-to-day practice. Malignancy and urological malignancy accounts for 80% of adult urology, and 4 out of 10 of the commonest solid malignancies. And as you can see there, it is a very common urological malignancy. Urology presents very frequently to general practice day to day. Prostate, more common than the rest, bladder following thereafter, kidney, testis and penis being the rarest. We're going to talk about how patients are referred, their acute presentation. Often they're picked up incidentally, and more frequently than not, particularly with prostate, they're picked up on routine screening. So there's specific signs and symptoms. Patients often present with a lump in the testis or the penis, and practitioners are feeling prostates and picking up abnormal prostates, or they may feel an abnormal mass in the abdomen, and it's important to perform these examinations and continue to perform them. But the non-specific features are lower urinary tract symptoms and hematuria, which are very important to pick up in practice. The examination findings, as we've discussed, but the bedside test, the urine dipstick, very important. The MCNS, particularly with the advent of the new NICE guidelines. In-house, we infrequently still perform a urine cytology to check for high-grade malignancy. We often check their urea and creatinine, full blood count, and or a PSA, depending on what we find. We will perform any of these tests, such as an X-ray, if they've got loin pain, an ultrasound scan and or a CT scan, and I will discuss which types of investigations we commonly perform and when to perform them. Endoscopic investigations, we often assess the lower tract and the upper tract cystoscopically to assess for abnormal cells. The bladder is a storage organ and a voiding organ, so we often assess for lower urinary tract symptoms, both voiding and filling symptoms. So do they have poor flow, hesitancy, intermittency? Do they have filling symptoms? Though these aren't a marker of malignancy per se, they are very important in the history. When we assess for hematuria, we often ask them, is it visible or non-visible? And if it's non-visible, we perform a dipstick and we assess it through routine testing this way. In the investigations, you refer them under the 2-week wait pathway, and we often perform a flexible cystoscopy, checking for malignancy. And if a malignancy is seen on the right-hand side, you'll see that there is a small transitional cell carcinoma there within the bladder, visible. We will often assess depending on if they have non-visible hematuria, an ultrasound scan, and on the ultrasound image on the top there, you'll see a mass in the bladder, and on the bottom ultrasound scan, you'll see hydronephrosis of the kidney. If they have visible hematuria, intractable visible hematuria, we'll often perform a CT scan to check for any filling defects within the upper tract. And this is an example of a filling defect within the upper tract to check for any of this transitional cell carcinoma within the upper tract. So, traditionally speaking, you will refer the patient under the NICE 2-week wait guidelines based on the non-visible hematuria or the visible hematuria pathway. But depending on how they fit within the age criteria, we'll often perform a flexible cystoscopy or an ultrasound scan. If they're under 40, an ultrasound scan to avoid the risk of radiation, and or a CT scan. But if they're over 40, they may well get a CT scan. If all is fine, we will discharge them back into your care. Now, if they have non-visible hematuria and we've excluded a UTI, but they have symptoms such as, like we've discussed, lower urinary tract symptoms, storage and voiding symptoms, with or without abdominal pain, we will often get an ultrasound scan. We may well get an X-ray to determine is there a stone, and a cystoscopy. But if there are signs of renal disease with an abnormal EGFR, a high blood pressure, or a abnormal PCR, a protein creatinine ratio, we will refer them on to nephrology. If they have asymptomatic, they don't have any symptoms, but despite that they have 3 positive dipsticks of blood, we will investigate that conventionally, as discussed before, if they're over 40. If they have renal disease, we will make an onward referral to nephrology, as previously discussed here. If they have an abnormal renal function, they should see a nephrologist. If normal, there is no need for any further investigations, as the chance of malignancy now is very, very rare. Prostate cancer, incredibly common male malignancy, and very often picked up now with the advent of multiparametric MRI. Again, a very common malignancy amongst men and growing in with multiple UK census being done. How do we pick it up? Well, PSA testing, digital rectal examination, lower urinary tract symptoms are frequently being picked up. On TURP chippings, we often pick them up, and often advanced presentation with bone pain, bilateral ureteric obstruction, metastatic spinal cord compression. So often performing a DRE is not particularly accurate, but by the time it's palpable disease, you're looking at really T2, T3 disease, really, before you can really feel it. At this juncture, we don't support screening for prostate cancer, but any man who wants a PSA test can have one, especially over 40 with a greater than 10-year life expectancy, or any man with a malignant feeling prostate should be offered a PSA test. I would add to that caveat also any patient with risk factors such as an Afro-Caribbean male or those with a family history within their first degree relatives. These are the commonly given maximum PSA derivatives here. So staging, how do we stage prostate cancer? Now we have with the advent of the UK Promise and Precision trial, we have palpable disease, T1, T2 disease, which is localized, or locally advanced disease, T3, T4 disease. So prior to biopsying the prostate transperineally, we would perform an MRI to localize the prostate. After we've biopsied the prostate, we gain histological diagnosis with Gleason. How aggressive is this prostate cancer? By giving it a Gleason score, it gives us a grade of aggressiveness. And it's graded 1 to 5. How do we stage prostate cancer? or we stage it, check for regional and nodal metastatic disease with a CT scan. And to check for bony mets, we get a bone scan. Treatment options for localized disease, early stage disease, depending on their age and performance status, you can watch most early prostate cancers. You can. If they're young and fit, you can, based on the PROTECT study, the 15-year study, you can watch prostate cancer with active surveillance for early prostate cancer, and NICE do recommend that. However, still options are still available to treat them radically with radical prostatectomy, radiotherapy, or focal therapy. As the disease progresses, however, radiotherapy, hormonal therapy, and possibly removing the prostate for locally advanced disease is a possibility, but a rarity. And of course, you can watch it at every stage, depending again on their performance status and comorbidity. Metastatic disease, you have hormonal therapy with or without chemotherapy and adjuncts following the introduction of the Stampede trial with abiraterone, enzalutamide to help. This is a radical prostatectomy, which I believe they perform at UHCW for treatment with radical curative intent, and they aim to preserve the nerves for sexual function here as well. Hormonal manipulation, and thank you for providing this within the context of primary care, acts as an LHRH analog. By giving the analog, you will provide a testosterone surge, but by giving the testosterone surge, you actually give a negative feedback to the hypothalamus. And by doing so, you inhibit the production of testosterone eventually. Bladder cancer, most present, very common incidence in the UK, mostly attributed prior to this with smoking, actually. 80% with painless visible hematuria. Other presentations are bladder pain, what we call malignant cystitis, very late presentations, obviously advanced metastatic disease with weight loss, loss of appetite, and very rarely incidental presentations. Trends are going down with the reduction in smoking and better education. And since the advent, I would say, of the NICE guidelines for 2-week weight referral. Trends in bladder cancer with age, obviously, the later the advance in age, they're more prevalent. Confirmatory diagnosis is traditionally picked up endoscopically, which is why assessment of the lower tract is very important, but particularly the upper tract. TURBT aims, one, to gain histological diagnosis under general anaesthetic with a loop, but furthermore to provide an accuracy for staging and grading, but can give you a disease assessment. So bladder cancer management depends on the type of cancer you have, the stage and grade you have, and overall, how well is your patient overall. So if this is a picture of the bladder, the yellow circle is your urothelium. As you can see there, that is TA, early cancer. T1, this cancer is now advanced into the about to advance, gone into the submucosa. T2, it's gone into the superficial muscle. And T4, now it's going well outside into the deep muscle. T4, it's spread right out. Okay. Now, for T1, TA, you can see 80% of those are managed conservatively by local endoscopic control and or intravesical treatments. The other two are managed more aggressively. That's normal, healthy urothelium. As you can see, the cellular architecture changes. In G1, G2, moderately differentiated. Again, the architecture changes. G3, poorly differentiated. Commonly, in the MDT, we'll say low grade and high grade. Most are low grade. T1, TA and T1, as I've said, are regularly managed endoscopically, and we can give special chemicals, mitomycin and or BCG, chemotherapy, immunotherapy, so to speak, to control things locally, to prevent recurrence and or progression. Locally advanced disease, T2, T4, are treated with cystectomy, radiotherapy, with or without the adjunct of chemotherapy before the cystectomy. On obviously metastatic disease, you are aiming at palliation. Radiotherapy there. Cystectomy is the removal en blanc of the bladder, the ureter there, and in the lady it will be the anterior pelvic clearance. With the formation of the urinary diversion, borrowing part of the ileum and forming a conduit. But you can also have an ileal neobladder, a new bladder, where you don't have to have a stoma. Again, these treatments are treatment with curative intent for T2, T4 disease, but may require chemotherapy beforehand. Renal cancer, again, a very common cancer, in my opinion. They don't often present with hematuria or a mass, as we used to read about it in the Oxford Handbook, but most are picked up incidentally. And I still haven't found cases, unless you work in regional centres where they are linked, you know, in your local DGH. I haven't seen a case linked to von Hippel-Lindau or polycystic kidneys or tubular sclerosis, though they are linked. You would investigate it if they did present with hematuria, both by investigating the upper and lower urinary tract endoscopically with a flexible cystoscopy and a CT scan, triple phase. And as you can see on the right-hand image there, a mass in the left kidney, but also it can present with metastatic cannibal disease. You can see the CT angio there, a massive filling defect. Tumours under 4 centimetres are commonly treated by nephron-sparing surgery to preserve as many good nephrons as possible, thereby obviating the need for renal dialysis later on, and the cardiovascular toxicities associated with poor renal function. This is a laparoscopic nephrectomy being performed. Transitional cell carcinomas of the urothelium, as I've said in my previous slide, when there is a filling defect in the upper tract, they must be picked up, and they are commonly treated by excising that kidney and the ureter en blanc. Testicular cancer. About 1,000 cases per year in the UK, affecting young males, and the testis and the mass themselves are often non-painful. Now, this is your incidence, teratoma, perhaps the younger side, younger male, seminoma, sort of 30s to 40s. Most lumps in the testicles aren't malignant, but will require, in my opinion, clinical examination, testicular tumour markers, and an ultrasound scan. That's an epididymal cyst. That's a lesion of the spermatic cord. That's a hydrocele. That's a hernia. Testicular cancers are usually intratesticular. The image there is an ultrasound image that shows a mass within the testis with unilateral testicular microlithosis, calcifications within the testis. You can see that the tumour markers there, we use alpha fetoprotein, beta HCG and LDH. We make an excision deep to the inguinal ring, removing the testis and the cord at the deep ring. to remove that testis, we have to assess their primary fertility. Have they completed their family? Because chemotherapy can affect their primary testicular reserve, and they may need adjuvant radiotherapy after. Staging, routine, thorax, abdomen, pelvis. Oncologically, they may need chemotherapy and/or radiotherapy after. They will need prolonged follow-up with our oncologist with regular CT scans and/or tumor markers. Depending on not whether they have a recurrence, they may need further cycles of chemotherapy and/or a retroperitoneal lymph node dissection at a tertiary center. Though the incidence is increasing, in my opinion, by promotion of men's health and men becoming more aware, the incidence is, the mortality is getting better. One, firstly, in the 1980s and 90s with the advent of radiotherapy for this, and better chemotherapy drugs are being available. Penile cancer, very rare cancer, presenting in usually over the age of 50 years old in uncircumcised men, often presenting late with a mass on the penis or the prepuce, and it is traditionally not painful. It can be a fungating mass, hard, palpable. By late presentation, it can advance into the inguinal nodes. The aim is to confirm the diagnosis. If there is any evidence of PEIN, then a circumcision may be curative with or without topical chemotherapy treatments. However, surgery aims to cure the cancer, but furthermore, also provide a degree of function for the patient. So it can be a total penectomy, it can be a partial penectomy if it's advanced for conservative treatment. So other treatments include radical radiotherapy, chemotherapy at late stages, and if the disease is advanced, they have to excise the lymph nodes as well. So in my time as a urologist, the management of urological cancers is not just surgical. It involves the multidisciplinary team, the primary care physician, the oncologist, the specialist nurse, and everyone around. And thank you very much for listening to me.
Right, ladies and gentlemen, do you have questions? Don't be shy. Anyone with any questions?
I was just going to ask about you said about tumour markers in testicular lumps. That's not something I've really requested before, and I wondered, is that something that GPs often do request, or that you would advise we do with testicular lumps?
Oh, hi, Emily. No, we usually routinely do that for if the mass is suspicious and we think, oh God, this mass doesn't feel right, we would just do that straight off. Yeah.
They wouldn't be advised to do that before referral, no.
Anybody else? Okay, there's a question in the chat function. How long would you suggest to leave between MSUs when testing for non-visible hematuria?
if the MSU is positive, so can you hear me?
Yeah.
If the MSU is positive, I would leave it 6 weeks. Yeah.
Okay, and another question, is PSA monitoring still valuable?
This is a personal reflection. Yes. But I use it in conjunction with MRI. I suspect
Okay.
in my time, we'll have something else. Like a biomarker.
Any other questions? Right, well, if there are no further questions, and I mean, if you have any other urological questions whilst you've got Mr. Kaba here, if you want. Oh, hang on, I'm being told somebody's got their hand up. Oh, Eva, do you want to come off mute and ask your question?
Yeah, thank you, Mel. Can you hear me?
Yeah.
Thank you. I wanted to ask more about hematuria, if that's all right, Mr. Kaba. Is there any difference in doing a dip and seeing blood on the dip in microscopic hematuria, and then sending MSU and then seeing, let's say, 100 red cells on there? Which one is more accurate, if that's possible to answer?
The high-powered field in the microscopy is better, but I mean, who's going to wait for that in day-to-day practice? I think it's impossible. You know, the exam answers always you'd wait for the microscopy, but in practice, you rely on what you have day to day. Eva,
Yeah.
You know, if the dip's
No, that's
positive, you know,
that's
the
absolutely
dip's,
fine. It was more occasionally it happens that you have a normal, at least documented normal dip, and I
Yeah.
presume that's obviously depending on who's reading the dip
Mm.
and whether the dipsticks are in date and have been kept appropriately.
Yeah.
So you can have normal dip and then you send MSU and all of a sudden you get 100 red cells.
Yeah.
So I would obviously take that, I presume, then, because that's more accurate in a way.
Yeah.
Yeah, perfect. Thank you.
Any more questions? Either take yourself off mute or type in. Okay, is there a role for sending urine cytology? Oh, hang on, let me just look at that question. It popped up on my screen. Is there a role for sending urine cytology in primary care?
No. The honest answer is cytology is a funny little thing, that cytology. Urine cytology, if you were mentally, as a urologist, if you thought, I'm sure that red patch is commensurate with something high grade, and you really wanted to try and avoid a cystoscopy, a GA cystoscopy, a cytology would help you confirm that urothelium wasn't high grade. So it helps you identify whether or not something's high grade. But if it's negative in the presence of a low grade malignancy, it's not that helpful. So it doesn't exclude anything low grade. It just tells you if something's not high grade. Is that helpful? So in certain situations, it will say, it might be helpful, but only in the right context.
Thank you. Is there any preferred medication for hormonal manipulation in prostate cancer, as different consultants have different preferences?
Good question. I always used to prefer Zoladex. It was 3 monthly. But since COVID, and to reduce the throughput through primary care, I opted for the 6 monthly preparation, and then Baus came, the British Association of Urologists advocated a 6-monthly preparation for the LHRH analog. I personally prefer that. The patient outcomes are the same. They practice less, or the person delivering the injection less. That frees up more slots in primary care. They have less injections by half. So if it were me, I'd like 50% less injections, please. But that's just me being a human, perhaps. The PSA result's still the same.
Thank you. Eva?
Sorry, me again, back to the hematuria, if that's all right. The 2-week wait guidance has fairly recently changed locally.
Really?
So it used to be that over 40, we've sent every microscopic hematuria for cystoscopy, which I can totally understand why you wouldn't want to do. But what are we supposed to do now with, I don't know, 42-year-old woman with microscopic hematuria, no infection?
Yeah, this is a tricky question, because nice practice has changed. In my personal practice, I don't manage them that way. I still treat it as a 2-week wait. I still treat it as an urgent and investigate, and my colleagues do the same. So if it was a 42-year-old, I would still do an ultrasound scan, a flexible cystoscopy, an EGFR, and a blood pressure. If that was all negative, I'd say, dear Eva, thank you for your referral. All is negative and all is clear. But nice say, the patient has to be, you have to exclude a urinary tract infection, and they have to be over a certain age. Do you know what I mean? So, which pathway that they come in under, it can be up for debate, but there have been some cases fairly recently and there aren't few, that have had squamous cell cancer, that have had recurrent UTIs and non-visible hematuria, that have had fairly large cancers.
Okay, so I suppose if it wouldn't necessarily meet 2-week wait referral, but if he is still worried and no answers, refer anyway?
Yeah, I absolutely refer. I'd be happy for you to drop me an email. Yeah, no problem. That you're worried.
Okay.
Yeah, and I can upgrade it. Yeah.
Okay, thank you.
Yeah, no problem.
I have another question here. The MHRA is discouraging fluoroquinolone use.
Yeah.
What's the best alternative for urinary tract / renal infections?
I would send an MSU first. And then based on that, fluoroquinolones aren't the best. My colleague's right. Yeah, nitrofurantoin is not a bad option. Yeah.
Thank you. Are there any more questions, ladies and gentlemen? If there are not, then I will say thank you very much, Mr. Kaba.
Thank you. If there's any other topics people want me to talk about, just give me advance notice, whether that's LUT, CD, or yeah. Okay.
And thank you, ladies and gentlemen. If you could fill in the feedback, that would be great. And we will then send out CPD and a recording to you. And we will look forward to seeing you at another lecture soon.
Thank you. God bless.
You.
Bye-bye. Bye-bye.
Bye.
Thank you.
Thank you. Thank you, Mel.
Bye.